pressure, contributes to the mean arterial pressure, because the body spends more time in diastole, right, than systole. So mean arterial pressure, basically blood pressure. The reason we need that, right, is perfusion pressure, is to perfuse organs and tissues. That's why we need blood pressure. That's why your body controls your blood pressure so judiciously, right? There's no room for error. If it's too high, it can be bad. Too much blood flow to the tissue. If the pressure is too low, but equally bad, too little blood flow, it causes hypoxia, the case of oxygen delivery. So we always, if it's low, we bring it up. We want to bring it up quickly. If it's high, we want to bring it down quickly. Yeah. So this is why. So this is MAP. Now, what determines MAP? Mean arterial pressure, and indirectly determines perfusion pressure. It's going to be cardiac output, right? So two major organs, the heart, cardiac output, and what the heart cardiac output, the vessels, CPR, and I do like putting the kidneys here too. Yeah, kidneys, because kidneys determine blood volume, right? So I need volume to get blood to the heart. Then the heart will pump the blood out or circulate, create pressure to circulate the blood. And then also need TPR, right? Which contributes, the peripheral resistance contributes to what? Mean arterial pressure. So if the pressure in the if there's resistance in the peripheral vessels, blood can flow to the vital organs. If there's no pressure in the peripheral vessels, then blood will flow to the periphery, like the skin. It's going to be taken away from the vital organs, right? Which is a bad thing in that case, yeah. So, but these are your major players that control MAP: heart, vessel, kidneys. Cardiac output, heart; TPR, the function of the vessels; and then the kidneys, we're going to talk about that. What they do, mostly sodium water reduction, right? Blood volume. How do you control these guys? Two things for control: RAS and what? Sympathetic nervous system, right? That's how you control these players and control MAP, RAS and SNS, sympathetic nervous system, or maybe autonomic nervous system, both simple and parasympathetic, depending on if you're dealing with hypertension or hypotension. But primarily sympathetic will be the major player, but para too can play a role. So let me just put it here as the opposite, right, to sympathetic. So, and RAS can control what? Cardiac output, right? It can also, it affects TPR and affects the kidneys. Sympathetic too, same thing. Cardiac output and TPR mostly, and it has some effect on the kidneys as well. So this is how you control, right, these players, and in turn controls what? MAP and perfusion pressure. Any questions so far? Stay with me up to this point. Okay. What determines cardiac? So how do we measure cardiac output? Cardiac output is what? The total volume of blood the body pumps out, right? And sorry, the heart pumps out per minute. So I need volume, the volume pumped out per contraction, and I'm going to figure out how many times the heart contracts. That's your heart rate. And the stroke volume depends on what? Depends on venous return, which is the one you call preload, and contractility. So venous return. So the blood return to the heart is what the heart will pump out, right? So the blood return to the heart is what the heart will pump out. So blood returns, the heart contracts, pushes blood out by contraction, that's stroke volume, and it's going to do that multiple times, right, per minute. That's the rate, the frequency, heart rate. So we put those two together, we have what? The overall cardiac output, right, per minute in that patient. and this is primarily controlled what sympathetic nervous system. So in the heart, we have what beta 1 receptor, which is sympathetic. Then you have the counterpart M2, right, which is para. Beta 1 will increase everything, increase contractility, increase heart rate. Then we know the kidneys can increase venous return, right? So volume. Also RAS. RAS can affect venous return through aldosterone and working on the kidneys. Sympathetic can increase contractility, stroke volume, heart rate, yeah, cardiac output. TPR typically controlled by what? We have the vessels. They have alpha 1 receptor, which constricts. They also have vasopressin receptor, V1, as angiotensin 2 receptor, right? All these are constrictors and they can increase TPR, while beta 2 in the vessels and M3 are dilators. So these guys dilate. You stimulate beta 2 and M3, that would decrease TPR. These guys increase TPR, they constrict. So that's how you control the vessels and control TPR. So there's an interplay with sympathetic, right? Alpha 1 and then AT2, RAS, and then you have the vasopressin, right? Which is V1, beta 2 is sympathetic, M3 is para, right? Then kidneys, right? Mostly it's just going to be volume and water, right? Their job is to create preload, blood volume, right? So water, sodium reabsorption under the influence of aldosterone, right? RAS system, yeah, which will in turn increase venous return and increase cardiac output, right? So these are your players. What are the implications here from this formula? Let's talk about some few applications. First application, I can use this to predict compensation. You can use this, right, to predict how the body will respond, right, in different states of blood pressure. So, and the two major states, right? So remember, we want to maintain homeostasis. The two things is pressure can drop or increase. Two major states of MAP can either drop. Two major deviations from homeostasis is MAP can drop, which means perfusion pressure will drop, or it can increase. If MAP drops, mean arterial pressure is low. And as you can see here, right, there are so many reasons why mean arterial pressure will drop. So many reasons why it can drop. It could be due to what? Low cardiac output, right? Let's talk about that pathology. So why will perfusion pressure drop? MAP drop. It could be due to low cardiac output. And low cardiac output can be due to what? It could be due to abnormal heart rate. Both tachycardia and bradycardia can cause low cardiac output, both of them, both for different reasons. If the heart is pumping too slow, I'm not pumping out blood fast enough, frequently enough, cardiac output will go down. If the heart is pumping too fast, there is no time to relax and fill with blood. So if it's not filling with blood, there's less blood to pump out. So tachyarrhythmias to cause what? Low cardiac output. Yeah. Cardiac output can also be low because of what? Low stroke volume. Why will stroke volume be low? Decreased contractility or decreased venous return. So patient has blockage in their RAS system. RAS is blocked. Maybe medications. Or something wrong with the adrenal gland, adrenal insufficiency, no aldosterone. Venous return goes down. Patient is bleeding. Patient is dehydrated. Preload down, SV down, cardiac output down. What will decrease contractility? Something's wrong with the muscles. Low calcium in the muscles. Muscle death, muscle injury, contractile protein injury, the cardiomyopathies, myocardial infarction, no ATP production, right? Ischemia, contractility drops, SV drops, cardiac output drops, MAP drops, perfusion pressure drops, right? Why else would MAP drop? MAP can, if cardiac output is normal, MAP we can drop, right, due to decrease in TPR, right? Drop in TPR can decrease MAP, which will decrease perfusion pressure. So what will decrease TPR? Vasodilators. Either things that are blocking, now medication, farm, right? Medications that are blocking alpha 1 or SINs, medications that are blocking V1, medications blocking AT2, RAS system will dilate the vessels. Medications stimulating beta 2 or M3, acetylcholine, will decrease TPR. MAP will drop, perfusion pressure drops. Right. We can use that has two implications. First implication is it can tell you that tells about the side effects of the medications, right? That we just listed. It can cause hypotension or orthostasis, static hypotension. Also tells me mechanism of action, right? Of vasodilators that treat what? Hypertension, right? So if pressure is high, I want to bring pressure down. I can target TPR to do that. Right? If pressure is high, I want to bring pressure down. I can target the heart to do that by giving what? Beta blockers, for instance, calcium channel blockers. They're going to decrease heart rate, block sympathetic, block RAS, decrease heart rate, decrease venous return, decrease contractility, cardiac output drops, MEP drops. So treatment for hypertension, as well as also tell you about the side effects of drugs at work, right? To decrease MEP here. So you can go back and forth. Either way, the mechanism makes sense based on this. MAP can also drop due to a problem with the kidneys. Right, I'm not getting volume. Preload is low. I'm blocking RAS, blocking renin, blocking aldosterone, ACE inhibitors, blocking ACE enzyme, blocking ARB, angiotensin receptor blockers, blocking aldosterone, right? Yeah, no volume, no fluid reabsorption, adrenal insufficiency, right? That will also, right, contribute to low MAP because the kidneys are not getting blood in, right, or maintaining blood volume. So that's one application of this, right? Things that can cause hypertension. Second thing we can deduce here is I can predict compensation for hypotension with this formula. All you need to know is what is the cause of the hypotension first. Then the other players will compensate, if that makes sense. For instance, patient is hypotensive because of what? Low cardiac output. Which players will compensate? TPR and the kidneys will compensate because they are normal, right? In that case, patient has low cardiac, low blood pressure because the heart is failing, low contractility. What will be the compensation? Increase TPR and increase what? Renal reabsorption of sodium and water. That will be the compensation. Oh, patient is hypotensive because TPR is low. What will be the compensation? The heart and the kidney will compensate. Now you're going to see increased cardiac output and increased renal reabsorption of water, right? So this is how the body maintains MAP. Make sure it's normal. If one system goes down, one of the players go down, or one of the players is the reason why there's hypotension, pressure goes down, the RAS will be activated. RAS will be activated, sympathetic will be activated, and the other players will compensate immediately to bring the pressure back up in the opposite direction. So that's second thing you can deduce here. Which means if I give you a question where a patient has hypotension because of low cardiac output, you know the heart is failing. So you know, okay, pressure is low is because of low cardiac output. And they are telling you that what? There's no compensation, right? TPR is low, is not increased. TPR should be increased, right, to compensate, but it's low. The question may be asking you, what other medication is patient taking? Or what is wrong with this patient, right? You may be thinking the patient is taking what? Alpha 1 blocker. Yeah, something's wrong with the vessels. I'm blocking alpha 1 maybe, and the vessels can't constrict to compensate, right, for low blood pressure. Or patient has hypotension because of what? Decreased TPR, but they also tell you that what, there's no reflex tachycardia, which is wrong. There should be reflex tachycardia. Pressure is low because of low TPR. The heart should compensate. Heart rate should increase. SV should increase, right? Cardiac output should increase to compensate. But you don't see that. They tell you the patient's heart rate is still normal or low. Now the question will be telling you what else is wrong with this patient, right? Why is there no compensation? Then once you know, okay, the heart is not compensating, right? Look at what is affecting heart rate. Okay, I'm blocking beta 1 receptor in the heart, or I'm stimulating M2 receptor. Yeah, there's damage to the sympathetic fibers that supply the heart, right? Something like that. So you won't see that compensation in that case. Yeah. So those are gonna be the same thing. Cardiac output is something's wrong with the heart or TPR, and you don't see the renal compensation, right? Patient is still orthostatic. Then you think if something's wrong with RAS, maybe something's wrong with the adrenal gland. The kidneys are not responding to aldosterone, right? Or patients taking aldosterone receptor blockers, ACE inhibitors, ARB. So you can use this to predict expected compensation for hypotension, as well as if the compensation is not seen, what could be, right, causing it. Yeah. Are you guys still with me or not? Victoria, still here? Margaret, okay. Natasha, good. Okay. So another application here will be what? Shock. What is shock, guys? What is shock? In your own terms, anyone? What do you think the word shock means? SHOCK. What is shock? Sudden change in. Okay. So shock is basically what? Vital organ hypoperfusion. In simple terms. Yes, like you said. So we're not getting blood flow to the vital organs. If I'm not getting blood flow to the vital organs, which means I'm not delivering oxygen, I'm not delivering glucose, I'm not right. Yeah, they can make ATP. So anything that basically decreases, right, perfusion pressure is shock. Right. I don't have pressure to deliver oxygen, deliver blood to tissue. That is shock. That is why it's not a coincidence that what every shock, right, has low mean arterial pressure. Yeah, if you look at shock, they all have hypotension. Yeah, because we just said to generate perfusion pressure, we need mean arterial pressure to do that. Or literally, mean arterial pressure is the perfusion pressure. Yeah. So if shock means low perfusion of vital organs, why would there be no perfusion of vital organs like the brain, the heart, the kidneys, the GIT? Is if right if the pressure is low. Low pressure will cause low perfusion. So if I want to know the causes of shock, then my question would be, what are the causes of low pressure, right? Which we have here already. Heart vessels, primary players, as well as the RAS system. Yeah. So heart vessels, RAS through the kidneys and stuff. So that's why you can divide the causes of shock into classification, right? Causes of shock due to low contractility, we call that word cardiogenic shock. Due to low contractility and problem with heart rate. That's cardiogenic shock. If the cause of shock is low preload and don't have enough blood volume, patient doesn't have enough blood volume, or there's low venous return to the heart, that's what hypovolemic shock, right? Because of shock is decreased preload, hypovolemic shock. Yeah. Let me ask you guys a question. So you can see hypovolemic shock and cardiogenic shock, right? They are both affecting cardiac output. They decrease cardiac output. That's why mean arterial pressure is low. That's why there's low perfusion pressure. Kentasha, how do you think the body will compensate in this case? If a patient has low MAP because of either hypovolemia or problem with the heart, cardiogenic shock, how will the body compensate? Thank you very much. Good. So what happens to TPR in that case? It will have to go up. Good. Very good. So TPR will have to go up. And that is why in a patient with hypovolemic shock and cardiogenic shock, if I constrict the peripheral vessels, they have peripheral vessel constriction, what happens to their skin? If you touch their skin will be cold and pale because there's no blood flow to the skin. You've contracted all the vessels to the periphery, trying to divert blood away from the periphery, right, back to the central circulation to maintain pressure. So the skin is not getting perfused at all. So you touch their skin will be pale and cold to the touch because of peripheral vasoconstriction. That is one way your examiner can tell you, right, what kind of shock you're dealing with. Once you see that, so the patient is in shock, they told you the skin is cold and pale, which means there's cutaneous hypoperfusion. Automatically you're thinking, oh, there's peripheral vasoconstriction. There's increased TPR. It has to be either hypovolemic shock or cardiogenic shock that you're dealing with. And to tell them apart, look for the volume status in the body. Look at the CVP, central venous pressure. Look at PCWP. Those tells you about the volume status in the veins and in the heart. If those two are low, you know it's hypovolemic shock. If they are high, then it's cardiogenic, right? Shock. Yeah. On the other end of the spectrum, shock may be due to what? Low TPR, right? Those are the category we call what? Distributive shock. If the cause of shock is low TPR, TPR goes down. That's why a patient is in shock. We call that distributive shock. Because in those cases, when TPR goes down, blood will leave, right? Blood will flow to the part of what? Least resistance. So if there's peripheral vasodilation, blood will leave. Blood will be distributed away from the vital organs to the periphery, to the skin, yeah, the non-vital organs. Because now their vessels are dilated, there's less resistance. So that's why this was also called shock, so called distributive shock. But under here, so anything that causes vasodilation will cause this. So that's where you now have septic shock under this category. We have septic shock under this category, distributive shock. We have anaphylaxis under this category, and then we have neurogenic shock. Septic, anaphylaxis, neurogenic. So septic, patient has a lot of endotoxins in the blood, right, and cytokines. They can dilate the vessels. Anaphylaxis, patient is allergic to something that is histamine release, right? Right, that will dilate the vessels. Neurogenic, there's spinal cord injury, so no sympathetic tone to the peripheral vessels. Yeah, dilate the vessels. And then you just look to tell them apart, you just look, they all have the same, they're gonna have the same, right? The TPR will be decreased, which is like once you see low TPR or their skin is flushed and warm, which means there's a lot of blood flow to the skin. Yeah, you definitely dealing with what distributive shock. So you can rule out cardiogenic, hypovolemic. You have these three. And then you just look for evidence of infection. Is there fever? Is there leukocytosis? Is there a source of infection? Then is septic. Is the patient also having bronchoconstriction with urticaria on the skin? You know, it's anaphylactic. Is the patient having neurologic deficits? Evidence of spinal cord injury, bilateral lower extremity weakness, and go. Then it's neurogenic, right? Yeah, sure. In hypovolemic shock, sorry, in distributive shock rather. Distributive shock. Victoria, if the cause of shock is distributive shock, any of these three, septic, anaphylactic, neurogenic, how will the body compensate? Hmm. The primary reason the patient is in shock is low TPR, correct? In distributive shock. So how will the body compensate? What will the body do to bring pressure back up? By increasing what? Cardiac, right? So now the kidneys and the heart, correct? The primary problem is in the vessels. So if the vessel is the cause of shock, then the other two players I have, right, to compensate is what? The heart and the kidneys. So what happens to the heart? What would heart do? It's going to increase cardiac output, right? Yeah. Increase contractility, increase artery, increase cardiac output to bring the pressure back up. Then the kidneys will start reabsorbing what? More water, more sodium to increase preload and blood volume. Yeah. Makes sense? Right. Okay. Margaret, there's one. So out of our distributive shocks, right, the septic and anaphylactic neurogenic, which one may not have that reflex tachycardia? Which one may not show that reflex tachycardia? Theoretically, they should compensate, right, by increasing cardiac output. But which one do you think will not show that? May not show that reflex tachycardia? The neurogenic will not show it. Exactly. Very good. Right. Remember, for me to see, if pressure goes down, I sense the barreflex senses the pressure. If I want to bring cardiac output up to compensate, I would need to increase sympathetic tone to the heart, sympathetic to the heart, beta 1 receptor. But in neurogenic, there's damage to the nerves. There's damage. Either spinal cord injury or if they have peripheral neuropathy like in diabetes. Yes. So in that case, you may not see the reflex tachycardia, the reflex compensation from the heart. If it's in neurogenic shock, you may not see it because the nerves are damaged. So there's nothing to sense the pressure as well as stimulate, right? Yeah, the heart. Yeah. Nodal cells, yeah, they are pacemakers and all that, which means they can depolarize without stimulation. However, they are, you need to, for there to be compensation for hypotension, you need to increase their rate. They need to fire more often, right? The only thing, so they're under the influence of what? Sympathetic nervous system. If you leave them, if you denervate the heart, the resting heart rate will be what? About 60 to 100, right? For SC node. SC node beats at rest between 60 to 100 beats per minute. That is if, assuming the heart is denervated, you remove any nerve supply to the heart, the node. On its own is about 60 to 100. But remember, for there to be compensation for hypotension, I need to increase the heart rate. I need to induce tachycardia, which will in turn induce increased contractility. So only sympathetic tone can do that. SNOD cannot spontaneously increase their rate without input right from the sympathetic nervous system. Make sense? You get it? Right, right, right. So that is why, yeah. So even in this case, they're not going to respond. Yeah, if there's something wrong with the nerve, it's not going to respond. Okay, so that's shock. So talk about hypotension, talk about compensation, talk about what could prevent this compensation. Talked about shock, same formula. Also, you can apply this to hypertension. What are the mechanisms of hypertension? I can determine this, right, from this formula too. Yeah, if pressure is high. Why would the pressure be high? It may be due to problem with the if it's primary or secondary. Two broad categories. We have primary hypertension, secondary hypertension. For primary hypertension, there is no identifiable right underlying cause. So the mechanism could either be patient just has increased baseline sympathetic activity, or there's increased sodium and water absorption by the kidneys, right? Or they have increased resting peripheral muscle tone, right? Or TPR. So, but we don't really know why they're hypertensive. But it could be problem with the heart vessels or kidneys, increased volume. So primary. However, in secondary causes, where there's an underlying cause, it may be something affecting, right, any of the players we have here. Things increasing TPR, pheochromocytoma, right? And epinephrine, no epinephrine is high, catecholamines are high, alpha 1 is stimulated, TPR is high, patient will be hypertensive. Oh, patient has a problem with their RAS system. Renin is high from a tumor making renin. Aldosterone is high from an adrenal tumor. Yeah, then they can have increased volume in the blood, increased TPR, increased pressure. Secondary. Oh, anything that activates RAS. Secondary to what? Renal hypoperfusion. So renal artery stenosis from atherosclerosis. Renal artery stenosis from what? Fibromuscular dysplasia. Renal hypoperfusion from coarctation of the aorta. Yeah, all those things can activate RAS, which will lead to hypertension also. Yep. So, right. So, secondary causes, right? They're gonna fall right in this category too. Just based on these players, you can predict what will be secondary causes of hypertension. And if pressure is high, I can also predict how the body will compensate. Pressure is high and I sense high pressure, then I want to bring down the other players. So let's say pressure is high because of what? Increased TPR. Then I'm going to see reflex what? Bradycardia. Right. I'm going to inhibit sympathetic tone and activate parasympathetic. I'm going to suppress RAS so that potassium, so that kidneys will stop reabsorbing right, sodium and water. Bring volume down to bring the pressure back down. The pressure is high because of increased cardiac output, right? I might see decreased TPR and low renal function or low renal reabsorption, yeah, to compensate. So which whatever the cause, if pressure is high because the patient has kidney problem too, yeah, I might see compensation with the heart or the vessels, right? So you can, with this, you can go back and forth and get what you're talking about. All right. Any questions on this? Questions, 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 questions. Okay. All right. So I want you guys to go through these, master this by heart. Okay, you have a question? Go ahead. It will cause obstructive shock. Okay. Yeah, yeah. I know obstructive shock. Okay. Right. So obstructive shock is caused by things that decrease venous return, right, to the left side of the heart, like PE. So let's say this is the right heart, and this is the left ventricle. So obstructive shock can be due to something here, yeah, preventing. So blood returns to the right heart, but there's obstruction, right, to flow to the left heart. Another mechanism would be what? There's no blood returning to the right heart itself from the veins. Yeah, there's a block here. block here. So obstructive shock is basically there's volume in the veins, but it's not getting to the heart. It's not getting to the right heart, or it's getting to the right heart but not to the left heart. So causes will be what? PE. Pulmonary embolism, a large pulmonary embolus can completely obstruct the pulmonary artery and prevent blood from moving from the right heart to the left heart. So patient left heart is not pumping, getting blood, is not pumping out blood. Cardiac output goes down, right? Perfusion pressure goes down, right? Patient develops shock. Or another example with cardiac tamponade. In cardiac tamponade, there's fluid in the pericardium and it's compressing, right? The ventricles. So the ventricles are collapsed, basically. They are collapsed. The pressure in the ventricular chambers, arterial chambers is very, very high. So which means blood can't return. There's no blood flowing into the right heart as well as going to the left heart because of collapse, right, of those chambers, like in cardiac tamponade. So that is also obstructive shock. Yeah. So in that case, obstructive shock looks like cardiogenic. It looks very much like cardiogenic, except in what? CVP. Right. Because in cardiogenic shock, right, PCWP will be, so let me put them side by side. So they look very much alike. So what you're going to use would be cardiogenic and obstructive. And let me put hypovolemic here. So you can put it under the category of the cardiac output, right? Issue. So these guys, they're all going to have high TPR because they are a form of non-distributed, right, shock. But then, so CVP, PCWP, right? Then you can look at the cardiac index. Okay, here. So in CVP, central venous pressure, which is the pressure in the central veins, jugular veins, IVC, in cardiogenic shock, it's gonna be typically high because if they have right heart failure. In hypovolemic shock, it's going to be low. There's no volume. Now, pressure is going to be high, which makes sense because there's increased pressure either in here, in PE, that will back up. There's an obstruction that will back up right into the right heart, into the veins. Or in cardiac tamponade, there's high pressure in the heart and it's going to back up into the veins. So CVP will be increased. Now, it's PCWP that you're going to use to separate between cardiogenic and obstructive shock. PCWP is measuring left heart pressure. So in cardiogenic shock, left heart pressure is high because blood returns to the left heart, but the heart can't pump the blood out. So left heart is congested. So PWP is increased, cardiogenic, left heart failure. Obstructive shock, however, is going to be low because there's an obstruction to flow to the left heart. The pressure on the right will be high, but there's an obstruction getting that blood to the left side. So PCWP will be low in obstructive shock. In hypovolemic shock, it's going to be low too, right? Because I don't even have any volume at all. Return to the heart. Yeah.